Hi, everybody. I'm Dr. Rebekah Griffith, the EDDPT, and I am here with you today for a special episode of our podcast, Admit It or Not. This is going to be a little bit different format than what we normally do, and I have a fabulous panel of women with me today to discuss the things we did during the pandemic, the things that we did in the role of an emergency physical therapist, even though we weren't PTs necessarily practicing in the emergency department. But I just invited these different physical therapists here today so that we could each share with you a little bit of our experiences of the things we did and the memories we carry from our time during the initial waves of the pandemic. So Nicole, do you want to start by introducing yourself?
Yeah, sure. Hi, I'm Nicole Nexon. I am a physical therapist in New Jersey. I work in a subacute building with a long-term care unit as well. That's me.
Great, Joanna.
Hey, I'm Joanna Nobbe. I'm a physical therapist in New York City, and I work in acute care 3 days a week, and 2 days a week I have a private practice.
That's awesome. Taylor?
My name's Taylor Surrette. I just graduated from DPT school in May 2022 and have yet to take my board exam, but I work in acute care.
I love it. So most of us are acute care therapists, or as Nicole is in a subacute rehab type area, but all of us were definitely impacted by the COVID-19 pandemic, probably a little differently than our outpatient colleagues. And I think it's important for all physical therapists to kind of hear the story of how things went during the pandemic. And I know that different regions were hit differently. Joanna, if you want to kind of kick us off and tell us about your experience being in New York City.
Yeah, so I took a job in acute care in June of 2019 in a hospital uptown Manhattan. So we are a small satellite hospital of Columbia Presbyterian, New York Presbyterian Hospital. And so I started in acute care, and I came from a couple of years of outpatient PT practice. I was kind of dusting off my acute care skills and just kind of getting into the swing of things when the pandemic started. And here in New York City, especially uptown, we had and continue to have a pretty hard hit neighborhood. And I remember the day we had our first COVID patient, and then it basically felt like the house fell down. And it was basically just, we became a 100% COVID hospital for a period of time in the first wave of the pandemic, with the exception of these two gentlemen that shared a room, that they were the only COVID negative patients in the entire hospital. And we were all just in awe of how they didn't get it in the absence of vaccines or protections and the Wild West that we were all living in. But it was pretty intense in the first wave. And pretty soon after the wave started, the main hospital of New York Presbyterian, where Columbia Medical Center is, quickly established a proning team, which was led by a nurse, and it was an interdisciplinary team including physical therapy, occupational therapy, respiratory therapy, nursing, and ICU team doctors. And so I went to the main hospital and did a 12-hour training about participating in proning. And then for the first wave, I was on the proning team, which were very, very long days because our whole ICU was all COVID and everybody needed to be turned on these routine schedules. And during that time, we were also staff PTs. So the people who were not intubated or were admitted for COVID that had physical therapy needs, we were still working on the floors. We were still evaluating, giving discharge plans, even though discharge planning was absolute chaos.
I bet Nicole can speak to that.
Oh my gosh, I would love to hear from Nicole.
Joanna, before you continue, for people who don't know, can you just explain what proning is and why it was happening, why that was important?
Sure. So proning is a therapeutic intervention. It was developed with the ARDS population. So for patients that have advanced severe ARDS, patients in the ICU that are intubated are turned onto their stomach into the prone position to optimize oxygenation and just give the lungs a chance to recruit alveoli and rest and recover while they're getting treated for their respiratory distress. And for COVID patients, that has been a primary strategy, sometimes later in their course, sometimes right away, just to kind of buy time for therapeutics to work. And so it works by, it takes usually a respiratory therapist, the patient's nurse, and then the prone team with PT and OT. And then sometimes the ICU docs or residents are either helping or watching. We also had a lot of medics come through, so shout out to the medics who helped out. But it's a procedure that takes at least 5 people. The respiratory therapist kind of guards the endotracheal tube, and everything revolves around the ETT, the endotracheal tube. And so, we turn them. It's a whole production. There's a procedure. We created a protocol, and I believe it's published. I might be wrong about that. But they come onto their stomach. PT is really important in proning because they stay in the prone position for at least 16 to 18 hours. And they're often, the positioning is, not optimal. So they have to be turned for the tube. Skin breakdown is a major issue. And brachial plexus injuries are a major issue. So PT is kind of helpful. We kind of were trying to figure out what's the best positioning, because when the people who did survive, when they do come off of mechanical ventilation, by the way, when people are prone or supine, when they're in that level of care, they're heavily sedated and paralyzed. So they're not able to make small adjustments. They're not able to say if they're uncomfortable. So they often wake up with nerve injuries. So they often wake up with, drop foot and brachial plexus injuries. So, to be there early on and to kind of try to prevent those felt pretty meaningful. Skin breakdown is a huge, huge issue. And some of the skin breakdown was far surpassing any gross Google search you could ever do. But everyone did their best and continues to do their best. They're prone for about 18 hours. And actually in subsequent waves, in Delta waves, Omicron waves, they actually started to prolong prone time. So sometimes people are prone for, 2-3 days. When they supine them, they're only supine for 6 hours-ish. And it all just depends on their blood gases. So the team reassesses their blood gases. And sometimes you turn them supine and immediately they start to crash and we just flip them right back to prone. Okay. It is a process that takes a lot of people, a lot of, a big group, and we've continued to do it as needed, but not as heavily as the first wave. And
how many of those patients survived? What were your outcomes? Because that must have been really hard.
Yeah, not great. I've seen different numbers. I haven't scoured the literature too heavily, but so I don't want to quote anything that's not absolutely true by the literature. But there were a lot of people that did not make it. I was involved in one turn where the patient arrested and expired right on the table in front of us. And they're very fragile medically. So it's often a little nail biting the first time, turning a patient, not knowing how they're going to respond hemodynamically, cardiacally. It's definitely learned a lot coming from outpatient land. It was a really good crash course in ventilators and ICU care.
I think too that for me, when being in the ICUs with the patients who were prone and intubated, the thing that really got to me the most was how quiet it was.
Yeah.
Really how quiet it was, how quiet the patients were. When everyone is intubated, sedated, and paralyzed, it's so quiet. And that really got to me, especially when turning patients, how quiet they were, how still they were, and how unresponsive they were. When our job in the ICU is usually early mobility, right? This is last ditch mobility.
Yeah. It's true. Yeah, had a very grim feel a lot of the time. The first time I did it was the training in the big hospital, and this is just a massive New York City hospital, and they had turned all the ORs into ICU beds, and these big ORs that have this gross like neon lighting. It's underground. It's very dungeony. It's not meant for this, and there were just bed every which way to fit all the beds into the ORs. And it was just such a surreal experience to see all these patients, as you say, so like quiet, and they're alive, but the feeling is they're on the borderline. So yeah, it was interesting.
I had a colleague who was in New York City during this wave as well, and she was actually redeployed to the morgue. Did you have any experience with that?
I'm sorry, to the what?
To the morgue.
Oh, I heard about that. I didn't, thankfully, need to go there,
Yeah.
but I did hear about colleagues, that were recruited to, to like transport body bags, and we had a morgue truck outside our hospital, and so someone had to do that, but thankfully it wasn't me or my immediate colleagues.
That's crazy. So in a little while, I want to ask you kind of how you coped with that and like what suggestions you have for people who might be going through some stress related to that. But I'd like to hear from Taylor next about your experience as a student during the pandemic.
Yeah, so I actually was at Northeastern University, and I'm not sure if anyone's familiar, but they do a 6-month co-op program. So I decided to branch out and go to acute care. So that started the end of December 2019. The first 3 months I was on, it was normal, and we had kind of heard about COVID coming, and I was on the East Campus, which is more joint replacements and oncology. And then I switched right over, I think it was April. And that was right when COVID started. And of course, it was the bigger campus. So that's where I was. They had me, the co-op, and they had 2 rehab aides. Oh, and to preface this, I was not sent home because I was paid. It's a paid co-op. So all the students went home, but I stayed because I was an employee. But still also in my first year of grad school. And so there was me, 1 co-op, and then there were 2 rehab aides who were full-time as well. And so we all got put on a rotating schedule because of just trying to mitigate infection in the break room and everything. We split the staff in half. So I was by myself, and then the 2 rehab aides were on different schedule. And then I was redeployed to help with, I was on a COVID unit, but I was a runner. So I was supposed to help nursing and CNAs in any way that I could just to support them. So most of the time I was like in full PPE, just kind of in the hallways and running supplies to the rooms where they were in the room, and they wanted to preserve the PPE. So I'd wear mine all day. They'd wear theirs. And whenever they'd go into the room, then that would mean they wouldn't have to fully undress and put on a new set. So that's what I did. It also entailed answering call bells and doing the needle sticks for blood sugars, which is not in the scope of PT. And then what else did I do? I did transport, but that was a good 4 weeks that I was just in the COVID land, not doing physical therapy at all.
What did you take from that into your current career?
I think just kind of being able to step up and truly be out of my comfort zone and just do whatever was needed, because I decided that I wanted to be in healthcare, and I needed to kind of be brave and kind of grow up a little bit, because although I was a student and all of my friends were sent home and safely quarantining with their families, I think that it was really important that I was there. And I think that I'll take that with me in my future career that's just getting started. And I think I also learned to kind of appreciate the nurses a lot more because, I mean, not that I didn't respect them or anything, but we worked together as a team and we were on the same level playing field. I wasn't just the PT student. That like we were all in it together and we became friends and we all made the scrub caps and we had matching ones. And it was really interesting that when that first surge was over, going back to that unit and seeing all those nurses without the scrub caps and full PPE and just seeing each other in our normal roles again, but we had become really close.
Sounds like that was a good support system.
It was. I found that honestly, they were a better support system than anyone else, just because we were on the floor together the most. I did 10-hour shifts there. I honestly didn't even see the physical therapy team because I was on the COVID unit. They didn't want me in that room with them.
Yeah.
So it was really me and the nurses, which was good.
Yeah, it's a lot of skills, a lot of good work that you did, and a really good learning on how to integrate into a team. So I think as physical therapists in the acute care setting, a lot of us don't belong to one team, right? Like we belong to the whole hospital. So we drop in, drop out, and you might not have an opportunity to build those relationships.
Yeah, I agree. It was special. I think that's my favorite floor in that hospital. I don't work there any longer, but I was per diem for a little bit, but I'd always be happy to go back there and say hi to everyone. So that was one good thing that came out of it.
That's
Although
great.
scary.
That's
Although
awesome.
scary in the moment. Yeah.
Thanks for sharing that.
Yeah.
Nicole, you had a totally different experience from all of us.
I did somewhat. It was in some ways the same, though. I can kind of relate to some of the things, especially some of the things that Taylor was saying. I can kind of relate to that because you, like you said, like you belong to the hospital. Like, so the building that I'm in, the we are employees of the facility. We aren't contract, right? So I've also been there off and on for quite a while. I started there out of school and left into outpatient and came back, right? So that's kind of the feel. So I know a lot of these people. Like I know the nurses, I know the CNAs, like we've been working with them for a while. And I know like the rehab team really well, right? So that's kind of like the basis of where I'm coming from. But like what I would say was different was that like I also really knew the patients. Because when it started, so like I said, I'm probably like 2 hours south of Joanna, like I'm on the Jersey Shore. So we're watching like everything happening. And as soon as I start seeing cases in New York, like we know we have enough commuters. We're like, we're next, like it's coming. Like if something, it sounds gross, but if something's contagious in Manhattan, like we're gonna get it. Like there's enough commuters, like it's gonna make its way down. It just is. It is what it is. And so like we're watching it, and we're like, yeah, this is coming. Like for sure, this is coming. And then it like really starts to like crest in New York. Like you see it building and building, and then we start seeing things in our facility. And I remember, like it's just like we're watching it, and you don't. Like, what were you looking for in the beginning, right? Because I have patients who are already there. I have people who have COPD and CHF and everything, and they're literally coughing in your face as you're trying to teach them transfers, So there was a period where we didn't know what was going on. We also didn't have masks. So I come into work one day and I had this one patient and I like adored her. And she would just cough constantly. You all know where this is going. And I walk in and they're like, your patient has COVID. And I was like, okay, great. Right? Like directly in my face. Cause you know how close you are to people when you're transferring that. Like you are up in their business. So
PT is a contact sport.
Yes. Oh, undoubtedly. So it's like, I'm like, all right. But at this point, it's been like a week since I've seen her. So I'm like, you know what? I think I'm good. Like, I think I'm okay. but like, I know like my coworkers, like I'm asthmatic. My coworkers I know have underlying conditions. So everyone's kind of like, how is this going to play out for us now? You know, so there's that little bit of panic because you don't know what's going to happen. And like, you've been exposed, it's there. And it's kind of like Joanna said, the Wild West, like what's going to happen next? No one knows, you know? And so now we're like isolating people, and now we're like not letting visitors in. So people are pissed because we can't have visitors. And then other people are just absolutely panicked and they don't want their loved ones home. So now you start hitting like discharge problems, and you're like, we really need to get them out of here. And their families are like, we're not ready. We're not. I'm like, no, we need to get them out of here, you know? And we had people who were like so close to leaving and they delayed it by a couple of days. And then you end up with people who had influenza A and COVID, and then they're there forever. So now you have this population that's there. They've been communal for so long, you know, we're very communal, they're very communal. And now all of a sudden there's like pockets of people who were starting to isolate and pull aside. And you're like, what are we actually looking for? When are we isolating? How long are we isolating for? Like, what is the protocol? We had to fight to get N95s, you know, like you and I know, like we all know on this call, like I said, people cough in your face. Like there's no more droplet than that. Like you are right there. And in the beginning, when there wasn't enough PPE, they're like, the therapists don't really need N95s, do they? And we were like, perhaps we do, you know? So there's
perhaps
like that.
We do. I personally,
do.
I will die on the hill that physical therapy is an aerosolizing procedure.
I will too. And like, I can't even tell you, like, we're still in the planning meetings, like part of the building is on COVID. We have this like, you know, you walk in one day and there's this small unit, and then you walk in and there's like a whole unit closed off behind doors, and there's another unit, and you're like, I need an N95, you know? And you know that like you're the one watching out for yourself at this point. So we're trying to follow any guidance that's coming out. We're trying to find any research that's coming out, so like we can make sure that we're safe while doing this, and also to make sure that like, do we need to be there, you know? Because obviously our thoughts are, we need to keep these people safe, we need to keep them out of the ER. Yes, we need eyes on them. Yeah, like we need to make sure that they're okay. So
also, if you could take some folks from the ER as well
then there's that, right?
Yeah, so like we have nowhere to send people.
So then we are, you know, we're monitoring people, because we know, I mean, we all know that decreased activity and being bedbound are some of the things that are going to get you right back to the ER, particularly with like pulmonary issues. So we're like, all right, we need to figure out what is the line between activity and not too much activity, you know? So you end up walking into, I mean, vitals are, well, saying vitals are vital, you know, and we're all taking them anyway. But now, I mean, we're fighting over like PPE, and then everyone's trying to make sure they have a cart, trying to make sure you have a pulse ox, trying to make sure you have whatever. And you're going in there and you are like, every single move these people are making, you are monitoring, like you are like on them and watching. And sometimes you'd walk into a room, and I remember one day I walked into a room and they were like, oh, this patient is asymptomatic for COVID. And I'm like, okay, but they are positive, but asymptomatic. And I'm like, all right, we'll see, like this happens. I can't even tell you the amount of edema this patient had. I mean, up to their thighs. And I had been working with this patient 2 days ago. They had not had that edema, and they're tired. And I'm like, oh God. I came out and I was like, they're not asymptomatic. And they're like, well, they're not coughing. And I'm like, well, they're not asymptomatic. But again, we still don't have a solid list at this point of what symptoms actually are. You know, I'm going by things I'm seeing coming out of China, things I'm seeing coming out of New York, things I'm seeing coming out of Italy, like any information we can get, and just trying to relay that. I come in the next day, there is pitting edema up to his chest. And I was like, I can't keep this one on at the ER. Like, I'm sorry, like this one has to go, you know? So it's like, you're making calls.
So you transitioned into a frontline triager.
Yeah. And that's not normally, you know, and you're used to, in that situation, enough medical complexity that you know when it's something you can handle and something you can't, right? Like there is definitely, from outpatient to inpatient care, there is a line where like you're looking at things that are red flags in outpatient that in inpatient, you're like, I think we can still deal with this, you know? And now all of a sudden you're like, nope, not at all. And you're really pushing and looking at that line of like, what can I handle? What can they handle? What needs to go and what needs to stay? And there's not much guidance
Right.
on what it is. So you're literally relying on fatigue levels, on vitals, on just physical appearance, on function. Like you're just pulling all that together and just trying to give the nurses the best report you can. And then realizing that the hospital is triaging who they're taking anyway.
Yeah.
So it's just like, you know, the stakes in this were so different from like the triage and the just level of monitoring you're normally doing. It's kind of amped up.
How many patients did your facility lose?
We lost maybe 30. And that's short and long term. I want to say that's an estimate. I think there's pretty much more, but like, because, you know, after the subacute patients start getting it, as hard as you try and as isolated as the long-termers were, they start getting sick too.
Yeah.
You know, and now you are pulling people, some with cognitive deficits, out of the only situation they know and putting them in isolation rooms. So now fall risk is like through the roof. You know, and protocol is to keep the doors closed, to keep the hallways clear. But now you have someone who is known to be a fall risk, known for their cognitive deficits. How do you close the door on that person? You know, so now the nurses too are like, all right, do I keep the door closed because that's what's safest for everybody on this unit? Or do I open the door so that I can keep an eye on what's actually going on in there? You know, and again, that's where some of that teamwork starts to come in, because now I'm going in there, I'm in full PPE, I'm checking vitals, I'm making sure that I'm toileting everybody before I go. I'm making sure that their rooms are stocked with supplies before I go. Like if there's lunch coming, if you think that you're leaving that unit and there's lunch coming, like you better think differently, because you're going to be in there handing out trays and making sure that everyone's settled for lunch before you even think of leaving the unit, right? It doesn't matter. Like that's your job now. Your job is to make sure those rooms are stocked, make sure everyone has supplies, and to make sure that people have what they need. Because again, you want to minimize how people are coming in and out. And if you're already in, you're already in. So you're going to do the job. You know, so I mean, I would do ADLs with people. That's not my scope. But if I walk in and they're like, I really think I'd feel better if I got dressed. Like I've been wearing these clothes for 2 days. I feel disgusting. I'm like, all right, looks like we're going to wash and dress, you know, and you don't want your PT giving you a bath, because that's just, we don't know.
Yeah, it's not my spiritual gifts. I can tell you that. No,
we don't know
hard
what we're doing.
pass. No, yeah, like toileting, sure. Couldn't get your clothes on, okay. But like helping somebody like through a shower, like, I don't know why. It's a lot harder than it seems like it ought to be.
And even sponge bathing, you're like, I guess here's like you just wash your face first, you know?
Yeah,
let's think this through.
I don't know. Let's like check out the danger zones and see what we can do with that. Well, I think the other problem was just like the amount of time it took to respond to patients' needs. By the time you put everything on and went into a room. And for me too, when I would go into a room like that, like you said, you're not leaving anytime soon. Patients were so lonely. And when and I spent some time backing up our COVID team on the floor during our first winter surge. And during that time, I mean, it was all hands on deck. And I took all the patients who spoke Spanish, because I speak Spanish, and it's so hard to use an interpreter because we couldn't have any live interpreters. And the like video thing, it was so hard with masks for people to hear that. And then if you had the PAPR or you had the N95 and if you had the hood, like people couldn't understand you. So I basically spent like days of my life yelling at people in Spanish while simultaneously, like from a terrified perspective, taking their vitals over and over again while we tried to move from point A to point B. But at the end, all the patients would want me to stay. Yes. So I could talk to them. Yes. And they would want me to like share a meal with them, especially if their family had been successful in getting food into them. because a lot of our patients didn't want to eat the food either that was at the hospital. They wanted food provided by their families, and they would just want you to sit and like enjoy a meal with them, or like watch a show, or like, can you just hold my hand for a while? And there were times when that was necessary, but I can't imagine like the scope of that in a skilled nursing facility or a long-term care facility.
It was just, and then the thing too was like the people that I knew. So when, you know, you see people every day, right? Even the short term, even the subacuters. So you'd see them every day and like they're doing better and you're kind of bonding anyway. And then all of a sudden you are their only human interaction. And they already know you and they already feel like they have a relationship with you. And like they just, like you said, they want you to just stay and talk to me, please. Like I'm so lonely. I'm so scared, you know? And then when the long-termers start coming down, I mean, these are people I had known for years at this point, and the same thing, like they're lonely, they're scared, they don't know what's going on. No one wants to sit in that. And then you somehow have to leave them and then go do that with somebody else, you know? And I think that was a big part of it too, just like the constant emotional toll of like leaving people who you know are like not in a good place. Like, you know, they're lonely, you know that they're scared, and you've just done all you can, and you leave them and you go do it again, and you go do it again, and you go do it again.
And then you go home and hope to God you haven't infected your family.
Oh yeah. And you know, and then you go home and you like strip in your driveway and hope none of your neighbors see you. And then you like run directly to the shower after disinfecting yourself. And then, yeah. You know, so I'm trying to maintain like a sterile home while trying to like do this job. And it was just, I mean, I was successful, knock on wood, and like hope we're okay. But like I had COVID, I worked in a COVID unit, and like my family did not get it. So I feel like I worked really darn hard on that. And I remember when the wave finally broke and we were able to go do things again, and I was safe and recovered, and my family was safe, and my in-laws were safe, and we all knew everyone was clear. We went to my in-laws' house, and I remember I just like laid down on their deck and just laid there. And I was just like, it's just so nice to be around humans.
Yeah.
Like, and I'm very grateful for the fact that, and I'm sure like you know, Taylor and Joanna and Rebekah, you can see it too, like my coworkers, like I'm so grateful for them because we were a team, like we had each other. We didn't have any other people. And everyone would be like, oh, I miss people. And I'm like, at least in the chaos, I had a consistent team of people that I could rely on.
Yes. At our hospital, it's been different for every wave. And I think during every massive wave, I probably did something different. So some of the things that I did during the pandemic that I would consider like not typical PT type things. I mean, I vaccinated people. One of my favorite memories from the pandemic is vaccinating community members in a gay nightclub in downtown Denver in the middle of the day. Huge disco ball in the room while we're vaccinating people. The guy who brought pizza, I'm like, let's get you a shot. He's like, okay. And then he brings back everybody from the kitchen that works there. We got the construction people outside to come in and get a vaccine. And so for me, that was the best part, because at the end of the day, I got to go home and say to my kids, like, mom did something today to help stop the pandemic, not just to fight it, but to like actually help stop it. Some of the other things that we did during that time in our hospital, we had people work as transporters. We had people driving supplies places. We had people working in registration departments. We even redeployed some physical therapists as respiratory therapists, doing trach care, vent setting adjustments, chest PT, things like that. But for me, the two experiences that I had that stood out were, one night I went to what had previously been the neuro ICU, but it was now a double occupancy COVID ICU. And when you've got your normal ICU room, like you have that monitor that's like embedded and it goes to a central nurses station. So somebody's watching that monitor. But the problem is when you put a second patient in there, there's not a second monitor. So that second patient would be on a portable monitor. The problem with the portable monitor is it's not going anywhere. So it's only useful if you can see it. And so my job that night literally was to walk from room to room to room to room to make sure that the monitors hadn't died and the patients hadn't died. And everyone was prone, intubated, and sedated except one guy who had just been extubated. And so I also responded to every call light, because they weren't patients, they were nurses, because none of the patients were conscious. So every time the call light would ring, I would go and help that nurse as quickly as I could, and then go back and walk from room to room to room, staring at each machine and making sure it was okay. And I remember saying, like, when do you want me to like get somebody? You know, because none of the vitals looked good.
Mm-hmm.
And they'd say, well, you'll know. Like, when would you come get me normally? Come get me then. And that was scary. It was a lot of pressure. It was also like in the middle of the night, which I tell you, I am not a nighttime person. I'm a baby bird who likes to be up in the morning. But when I was homeschooling my kids all day, because the schools were closed, one thing that I could do to both keep my job, support my community and my family was to work at night. And so that was an experience that will stick with me. And during part of that, one of the things I was asked to do was to come in and help turn somebody who was on ECMO. And I swear to you, he looked just like my husband. And it was very sobering to help with that. But during our subsequent later waves, I think in this last December, January, I was working in the emergency department, but not as a physical therapist, just like literally as whatever they needed. Because a lot of people didn't want to redeploy to the emergency department because it's considered a COVID unit, because they don't know who has COVID and who doesn't. And we had so many patients that they were just lining the hallways, waiting to be seen. And some patients would be like, hey, you know, like, I've been here since 1 o'clock, it's 8 p.m. Nobody's seen me, like my lab tests are done, but I still haven't been to a room. And so people were very frustrated and they were miserable. Like, some people were lying on the floor on oxygen tanks. Some people were like sitting there vomiting repeatedly, and I would just change out the bags. But my job was to basically monitor the waiting room. And so I would take vitals and I would start at one end of the hallway and I would go all the way down and all the way back. And by the time I had made it through all of the patients, it was time to start over again. And my job was to help triage. Because if you think about it, physical therapists are pretty well suited to that, right? Like, we can tell if people are declining, we know how to interpret vitals, we know how to take them. And so, you know, if on my last pass, your temperature was 101 and now it's 106, like, we're moving you up the line. Your blood pressure is now 70/30. I'm going to get somebody to come and take a look at you. But also, like, ambulances were coming in, and my job was to get people off the gurneys and put them on the floor somewhere, or put them in a chair somewhere, because there was just nowhere for them to be seen. And I remember one patient who was just like miserable, like sitting in a chair. He looked so ill. Like, you know, when people look sick, and then, you know, when people look real sick, this guy looked real sick. And his primary complaint was ear pain. So for him, he was there for ear pain. And I remember just like following up, and later, like 2 days later, he was prone, sedated, and intubated in the COVID ICU. So it was quite the experience to work all night, just walking this same hallway, assessing people over and over again. And I won't forget that. I also won't forget on Thanksgiving, working on Thanksgiving in that same kind of role, like helping people out of their cars to come into the emergency department. Like, they didn't come by ambulance, but we would get these calls saying, you know, assistance needed in the ambulance bay, or the, you know, the place where words fail sometimes, the place where people drive up and they get out of their car. And my job was to go out there and like pull people out of their cars and get them into the building. And you would pull them out, you know, and you know what it's like to like dependently get somebody out of a car. They're like all over you. Oh, well, why are you here? I think I have COVID, you know, and they couldn't stand, they couldn't walk, and they were just all over you that whole time. And I think in some respects, it was so exhausting to still be doing this another Thanksgiving. And then at the end of the day, like, go home to family and like have Thanksgiving dinner and like feel like everything was normal when everything was anything but normal. So I don't know if anybody else had an experience like that, where it just felt like what you were doing all day and what people around you were doing was so in contrast that it was a little hard to manage.
Yeah. I felt like, I remember I would get up and everything here was like shut down. And like, you know, my kids were home because school was closed, and my husband was working from home and trying to juggle the kids. And I would drive past like all these closed businesses, and it was so quiet. And like, I mean, I live in a tourist area And in the winter, it's quieter, but there's people who are always here. You know what I mean? Like it's always busy here. And I would just drive into work and be like, there is no one on the road. Like there is no one getting coffee. There is no one, like there is no one. And it was just so surreal because then I'd hear people talk about how bored they were and how like they couldn't believe they couldn't just go to work, and like they didn't even think this was that real. And I would just like look at my day and just be like, I can't even understand. Like I can't even understand like the day that you're having, because my entire day is this disease. And you are debating whether or not it's even existing because you don't see it. Like people are so sheltered from the things that aren't part of their day, you know, and I'm sure there's things that I'm guilty of having those same feelings about. Like you don't understand because you don't know what you don't know. And it was just, I'd hear people talk and I was just trying to figure out like where their headspace was and how it reconciled with what I was seeing. And it was wild, like on a regular basis.
Well, I appreciate everybody's discussion and conversation in this episode. And in our next episode, we're going to talk more about other experiences we had during the pandemic, as well as different coping strategies that we all use to help us get through some of those things. So thank you to my guests, Nicole, Joanna, and Taylor. And we look forward to having you join us for our next episode. And in the meantime, please feel free to subscribe and share. And you can find our podcast on Sounder FM as well as YouTube. Thank you all so much for tuning in.